I'm just letting the board or the screen wake up. I know. Very loud today. Okay, move this down. We're going to do some path review today. We're going to, we have kind of 4 areas that I want to make sure we cover. Hematology, so we'll start with that one first. We have reproductive, and we have kidney, and we have neuro. So we'll get through this one first up top. We will then go into some neurology next. We'll then flow into nephrology, and we'll finish our day with reproductive. So that will be kind of our flow of our path section. All of the PowerPoints are posted online. Like yesterday with the micro stuff, we'll probably kind of jump around and we won't go through every single slide. I'll just try to kind of hit on some of the high yield pieces. And I want to emphasize today that if there's something you've never seen before at this point in the game, name recognition is great. But I wouldn't worry your mind about studying it too much at this point, a few days before NPLEX exam. Over the next couple of days, high yield stuff is going to be your best friend, but also give yourself a brain break, because realistically cramming at this point is not going to help your brain. You want it to be nice and fresh for your test. So allow yourself some rest over the weekend. All right. So again, for people who weren't here yesterday or who weren't online, we flip-flopped. We did micro yesterday, and so we're doing path today. The lecture from yesterday, the big kind of like screen recorded thing, 4-hour situation, is up online. So if you do want to review that, you're welcome to. Okay, so hematology review. First, we get into our clotting pathways. We've talked about the clotting pathway a little bit. We have our intrinsic and extrinsic pathway. A good way to remember the two is your intrinsic pathway is associated with blood trauma or collagen or blood contact, versus your extrinsic pathway is damage outside of blood vessels. So you could think of intrinsic as something that's happening within the blood vessel, within the actual site of blood flow, versus extrinsic is something that's occurring outside. So we are classic, like you get a cut, a wound of some kind. There's lots of other things that can affect it. Really understanding the numbers or the flow will probably help you the best. Our extrinsic factor, our extrinsic pathway, we have factors 2, 7, 9, and 10. These factors are also important because of why. Vitamin K. Yeah, if you have that, that's probably going to be your most common clotting question that you're asked about, is where vitamin K is involved or the factors involved with vitamin K. So if you have 2, 7, 9, and 10 with vitamin K, you are probably good for, and you understand the difference between intrinsic and extrinsic, you'll probably be fine for most of your clotting cascade questions. Iron handling, we've talked a little bit about iron at this point, so I'm not going to belabor this one too much. Just recognize, so this kind of is a little schema showing you diets. You have your heme iron and your free non-heme iron. Both of them are getting taken up through, this would be your gut intestinal epithelium. Heme iron, you have upregulated uptake into your plasma. Free non-heme iron, this is more regulated. You are actually going to bind it to transferrin, and then that's going to be transferred into systemic circulation to go into the liver. From there, the liver is going to take transferrin and create ferritin, which is a liver binding protein, and that's going to push that back out into the blood. Ferritin can enter into plasma, which is why we measure ferritin when we check for iron. Iron questions, typically not a lot of questions about iron metabolism in the body. Maybe where iron's absorbed. I see more iron questions on NPLEX too. Okay. Yes. It also is absorbed in the ileum a little bit. Yeah. So if they give you both choices, I would choose duodenum. Yeah. Versus B12 ileum. If they gave you both choices. They're all kind of absorbed a little bit everywhere in the small intestine. Yeah, so it's where it's absorbed the most. Good, good. No, this is just scary biochemistry, so we'll skip that. All right, going into some of the anemias. I want to just mention a few of the anemias. We're also going to talk about the leukemias as well. So overview, really anemia in general is defined as low hematocrit, low hemoglobin. They won't make you necessarily interpret lab values, but I have seen them give them to you before. So normal range of both of these is gender specific. So understand that depending on the gender you're talking about, the range is going to be slightly different. If you have a hematocrit below 36%, that's considered low. If you have a hemoglobin below 12, that's considered low. It doesn't necessarily mean anemia, right? Most of the time, they won't just give you lab values and make you interpret them, but I have seen that on NPLEX at least once. Let's see here. So looking at our anemia by MCV, this would be more high yields, understanding who's microcytic, normocytic, and macrocytic anemia. So our microcytics, the most common you're going to be tested on is iron deficiency, but understand that thalassemia would also fall in this category. For normocytic, we think of our acute blood loss, our anemia of chronic disease, or hemolysis. These would be probably the most commonly asked about. And your macrocytics, really folate or B12 deficiency. You can also see this in alcoholism or chronic liver disease. So those would be really your best bet for anemias, is just being able to separate out micro, normo, or macrocytic and the type of anemia it's associated with. You're not going to need to be able to interpret these values. So this is not high yield for your purposes, but if you're like, I have to know, this is really here for those people who need to like have that differentiation, that understanding. So we'll look at the microcytic hypochromic anemias first. We're going to look at iron deficiency and I believe thalassemia. So our thalassemias, this is a defect in the synthesis of either an alpha or beta chain. It's microcytic and hypochromic, so smaller cells with a higher hemoglobin than iron deficient anemia. We'll see these intraerythrocytic inclusions that can damage our red blood cell membrane, and that itself can cause the hemolysis that we can see with thalassemias. Beta thalassemia minor is associated or caused by decreased synthesis of the beta chains. You'll have one of two genes not present, so it's a heterozygous mutation. Given that you have a third genotype and third phenotype, what type of inheritance pattern would beta thalassemia minor fit? Sorry? Incomplete, absolutely. Incomplete inheritance. You have the three separate genotypes with three separate phenotypic expressions. If we remember, our typical classic expression is if we have dominant expression, it could be homozygous dominant or heterozygous dominant, or which would look the same phenotypically, it would express the same traits. Or we could have homozygous recessive, which would express something different. In incomplete dominance, we can see that our heterozygous, where we have one dominant and one recessive trait, will express something different phenotypically than if you're homozygous dominant or homozygous recessive. And we see that with beta thalassemia. So this would be a great genetics question for them to ask about incomplete dominance. Okay. Same as sickle cell, exactly. Yep. Good connection. Beta thalassemia major, both genes are defective or missing. So this is going to be a more significant, more severe disease. You'll see symptoms beginning approximately 4 to 6 months of life, severe anemia. You'll see wasting jaundice, failure to thrive, and delayed onset even of secondary sex features. Okay. So those would be the two, understanding really the codominance or the incomplete dominance pattern, I think would be the most important piece for beta thalassemia. And then it's a microcytic anemia, microcytic hypochromic. A macrocytic anemia, B12 deficiency, we've talked about this in the past. It's going to be macrocytic, larger cells. You could see elevated MCV, low reticulocytes. One interesting thing that they could ask about is you could see hypersegmented neutrophils. That's a histological component that's sometimes seen in micro or macrocytic vitamin B12 deficiency. Our hemolytic anemias, the one that we often are tested on is glucose 6-phosphate deficiency. It is the most common hemolytic anemia, and this is where you see bite cells or Heinz bodies on peripheral smear. G6PD, we already talked a little bit about how it's important to red blood cell integrity, red blood cell creation, and glutathione reductase supports this process. And so that's kind of where we get glutathione involved, is in that G6PD shunt. This condition itself can offer a selective advantage against malaria, because malaria infests the red blood cells. So you could see questions asked in comparison or in regards to malaria as being part of your case, or vice versa, as glucose 6-phosphate deficiency being part of the case, and then having a question on malaria. So don't be shocked if you see those two combined on an NPLEX exam. Okay. Sickle cell, we already talked a little bit about, someone brought it up. It's inherited disease. Essentially, you have a replacement of glutamic acid by valine at the position 6 of your beta chain, leads to that sickling of your hemoglobin, so the sickle cell association of your red blood cell. Anemia is obviously a big component, as well as splenomegaly, and you can have the sickle cell attack, where you have actual classic chest pain, stomach pain, bone pain. You could potentially even lead to infarctions in bone marrow or really significant complications. But this is another inheritance pattern that looks like beta thalassemia, where you have an incomplete dominant picture. So you can have a full recessive inheritance pattern where you're going to have the worst disease. You can have incomplete dominance where you get just one copy, and you're going to have a still expression of some sickle cells, but not all of your cells will be sickled, or obviously you could have none. Hereditary hemochromatosis, this is an inherited disorder. It results from excessive iron absorption from food. You'll see it manifesting in 40 to 60-year-old patients. Your clinical picture will look a lot like cirrhosis. You could also see pancreatic failure or diabetes called bronze diabetes, where you have this bronzing of the skin due to buildup of iron deposits and iron residue. Treatment is typically bleeding and iron avoidance. Okay. All right. We're now going to shift gears into some other bleeding disorders that can be asked about on your NPLEX. Yeah. Beta thalassemia, protective against malaria, is actually sickle cell. You can see beta thalassemia and malaria together as well, but sickle cell is the one that's classically talked about. Because in sickle cell anemia, your red blood cells are broken down faster than 120 days typically. And so you don't have time for the malarial plasmoid or plasmodium to actually go through its full life cycle in sickle cell, because the cells are breaking down too fast, which is why you see a lot more sickle cell in countries that are endemic with malaria. You'll also see that beta thalassemia is associated with malaria as well. And that's because it's similar. The red blood cells are going to break down a little bit faster. But sickle cell is the one that is classically tested on.
There's a question I did on like what's protective against malaria. You know, the thalassemia one.
Protective. It'd be the same idea. So it'd be the same idea as sickle cell. They have the same inheritance pattern, that incomplete dominance. So either beta thalassemia or sickle cell anemia, you have the incomplete dominant inheritance pattern. You still get the benefit of having a faster turnover of some of your cells. So you're not going to allow malaria to complete its actual cycle. Yeah. Yes. Yeah, absolutely. So if we look at G6PD, it also can offer a selective advantage against malaria. Malaria infests RBCs. It's where it completes its red blood cell cycle. In G6PD, we can see breakdown of our red blood cells quicker than normal, actually by macrophages, literally taking bites out of that's the bites cells, is macrophages trying to take bites out of our red blood cells that have this inappropriate metabolic component, or the Heinz bodies present. And when those bites happen, when the bite cells are present, that's going to break down our red blood cells faster. So you could, in theory, say anything that's going to shorten a red blood cell's life could be protective against malaria. Yeah, and that would probably be an easier association. So beta thalassemia, specifically if you're in the heterozygous, it's not going to have a significant disease. Same with sickle cell, and then our glucose 6-phosphate deficiency. But we could probably find more examples as well. Anything that shortens red blood cells' life, essentially, if you think about malaria as an infectious organism, its last developmental stage occurs in the erythrocyte. And so if you're breaking down those erythrocytes before it gets there, then it has to start all over by infecting new red blood cells. So you'd have to get a new infection. Goes red blood cell, liver, and then back into the blood. Yes, any other? This is good stuff. They do love asking about malaria and blood things, blood disorders. So this is a good conversation to have. Okay. All right, what was the malarial organism that's most common? And what's the most deadly? Yes, great. Falciparum deadly, vivax most common. Okay. So moving into some hemorrhagic disorders, is this going to be as high yield? I don't know. Probably not. Trying to think if there's anything I really would want you to care about at this point. I honestly wouldn't lean into those purpuras. The Henoch-Scholin purpura, this one would be more higher yield if we're going to talk about a purpura, a hemolytic disorder, a bleeding disorder. This one affects mainly children. You'll typically see an acute respiratory infection prior. So oftentimes when this is asked about in a case, it's in a case of an acute URI in a kid, and then they'll bring this case or condition in later. It's an inflammatory disorder with unknown complete etiology, but we see IgA dominant immune complexes in our smaller venules, capillaries, and arterioles. So if we're seeing IgA immune complexes, what type of hypersensitivity reaction would this be? If we're seeing free-floating complexes. 3, right? Free-floating IgA antigen complexes with complement, right? The triple threat, all 3 together, is associated with our hypersensitivity type 3, versus if I said these immune complexes are bound to the blood cell, what type would that be? 2, exactly. So this would be more characterized by a hypersensitivity type 3 because of the IgA antigen immune complexes that are moving through, specifically located in smaller venules, capillaries, and arterioles. You can see the purpuric rash, so the non-blanching rash on lower extremities, abdominal pain or kidney involvement, because if we have free-floating complexes and they're in some of our blood supply, they can get stopped or stuck in those smaller blood vessels, those smaller locations, hence the kidney involvement, and arthritis for that very same reason. If we have free-floating immune complexes and they get into the joint and they're leading to inflammation, we can see arthritis there. So this one I often see either asked in regards to identifying its IgA as the immunoglobulin or what type of hypersensitivity. So those would be your 2 more high yield components there. Idiopathic thrombocytopenic purpura, this is antibodies against your platelets. You'll also frequently see a URI or other viral infection precede it. You'll see petechia, and you can potentially see even central nervous system bleeding or bleeding gums. But the antibodies against platelets, that's the kicker for this one. That'd be your high yield. Again, so that was idiopathic. We have thrombotic thrombocytopenic purpura. This is fatal. The lifespan is typically 30 to 40 years, and it's due to an inhibitor of our VWF cleaving protease, von Willebrand factor cleaving protease, and unchecked platelet aggregation. Okay, so platelets are aggregating without being able to break down platelet aggregates, and we don't have the inhibition ability of von Willebrand factor VWF cleaving protease. So we have the inability to break down clots as they form. So hence the thrombotic thrombocytopenic purpura. Okay. You'll see these are diagnostic criteria. You don't need to know about that. But the one component that is histologically important would be you can see schistocytes or helmet cells on smear. So those would be pathognomonic for your thrombocytopenic thrombotic purpura. Your hemolytic uremic syndrome, this is typically in infants, children, or pregnant postpartum women. So that would be your category of people that be at higher risk. It is a hemolytic anemia, and you will see kidney failure. Etiology, think bacteria or drugs. So bacteria, when you're looking at bacterial illness that could cause it, sometimes it can be induced by your diarrheal illnesses. Our least favorite or favorite type of E. coli we talked about are O157H7. So remember, they have the O and the H antigen. We talked about that yesterday. Shigella, Staphylococcus species, or sometimes even other E. coli subtypes like E. hec, right? Our hemorrhagic form of E. coli. Drugs, some cases could be related to drugs. They won't ask you about specific medications. They might include like oral contraceptives in there just as a part of the case. But typically when they're asking about this syndrome, they're asking about a specific type of E. coli. So if you remember E. coli O157H7 or E. hec, the hemorrhagic form of E. coli, most of the time that's going to be where this question is driving you down. Von Willebrand disease is brought up because it's the most common hereditary coagulation disorder. There's multiple subvariants of the disease. Males and females are affected equally, but many people are never diagnosed. Oftentimes, females aren't diagnosed until they have their first child or first menstrual period, depending on the severity of the disease and the actual subvariant that they have. You'll see essentially an abnormal synthesis of von Willebrand factor, VWF, which will decrease platelet adhesion and decrease serum levels of factor VIII. So you'll have heavy menses, bloody nose, easy bruising, like all your classic symptoms of anemia. But you can even see GI bleeding in some patients with severe disease. But the kicker here for this one is most common hereditary coagulation disorder, abnormal synthesis of von Willebrand factor, decreased platelet adhesion, and factor VIII. Those would be the pieces I would pull together. I'll get to your hand. They'll often also try to get you to say it's more common in females than males. The only reason that would be the case is because we actually have a reason to see excessive bleeding more in females, given that we menstruate typically every month. But it doesn't mean that prevalence is actually more in females than males. Yes?
Do any of the subvariants
Always you bleed more von Willebrand's, but if we recall, if we go back to if we go back to thrombotic thrombocytopenic purpura, we have an issue with the von Willebrand's factor cleaving protease. And so we are unable to, so von Willebrand's factor is helping us bleed more. In this instance, we have an inability to cleave that off. So instead of being able to bleed, we're clotting. So we're unable to use von Willebrand factor effectively, essentially in this condition. But all of your von Willebrand factor disorders associate them with bleeding, not clotting. Yeah. I don't have a great way of remembering it. Maybe that capitalize the E in your brain in von Willebrand and then E and 8. That would be probably where I would try to go. Yeah, I'm not sure. I don't have a great mnemonic for that one. But it would be great if we had one. I'm sure someone's made it. Okay. DIC, the only time I really see this asked in regards to on NPLEX is if in regards to gram-negative bacteria or endotoxin release. That's when I could see a DIC question being asked. So if there is one asked in regards to or asking a relationship to a bacteria, your gram-negatives are going to be more of the culprits, and because they have endotoxins that they can release into circulation. I often don't see DIC asked about, have seen DIC in clinical practice, so it may be clinically pertinent, but not maybe for the NPLEX. Malignancy-wise, adenocarcinoma of pancreas and prostate, as well as acute leukemia, could set you up for this condition. So getting into some of the hemophilias. So this is a deficiency of factor VIII. So we have hemophilia A and hemophilia B that we'll look at, and then we'll get into some malignancy. Hemophilia A is factor VIII, hemophilia B is factor IX, okay? So A becomes before B, 8 and then 9. Hemophilia A is an X-linked recessive disorder. Obviously, you can do a factor VIII assay to diagnose. You'll see normal prothrombin and thrombin clot time. which is interesting. And treatment wise, I mean, they talk about treatments. You don't need to know anything regarding treatments. Really, the two things that you'll get asked about is the factor associated, so factor 8, and the inheritance pattern. So that would be the two pieces I would have in your brain. X-linked recessive, factor 8 with hemophilia A. Hemophilia B is deficiency of factor 9. It's also X-linked recessive. That would be your biggest component that I would remember about factor 9 and hemophilia B. So for these two, the factor and the recessive, X-linked recessive would be your most important high yield pieces. Now we're going to get into some malignancy questions and talk about the leukemias. Cancer is always a potential diagnosis. They like to ask about cancer on the NPLEX because we don't get to talk about it enough, I feel like, in our classes. But any of your classic symptoms could be clinical characteristics. So these aren't helpful. But if you do have a question or a case that's giving you weight loss, night sweats, fever, fatigue, pain, lymphadenopathy, think you might be going down the cancer pathway, right, for your diagnoses or for your questions. The first one I want to talk about is kind of related. So polycythemia. We have polycythemia vera and relative or reactive polycythemia. Relative or reactive polycythemia is the reaction to increased erythropoietin. What is EPO? It helps with production of our red blood cells, right? Our actual erythrocytosis. And where is it secreted from? The kidneys, and it's acting on where? Bone marrow. Great. So now we kind of have like our connection points, right? Okay, so this is a reaction to an increased secretion of EPO or increased concentration. And if kidneys are producing it, then we can say, okay, there might be some kidney stuff maybe that's going on or causing it. So if we look here, we can see some etiologies: renal arterial hypoxia, emphysema, tumors, or tetralogy of Fallot. All of these things could potentially cause this erythropoietin to be increased. We also could see in this condition high white blood cells, platelets, and obviously red blood cells, because if you're increasing cell creation, you're going to increase cell creation of all these things. Later, you could see marrow fibrosis because you've made the bone marrow work too hard, too fast, right? Fibrosis, think about the liver, right? If the liver is having to work overtime, we lie down collagen, we lie down fibers to help support that process of liver regeneration. Same thing can happen here with our reactive or relative polycythemia. So the bone marrow can become fibrotic, and if the bone marrow becomes fibrotic, it's going to over time work less effectively. Okay. This can lead to also acute myelogenous leukemia. So we see these acute large cells that are undifferentiated. They're white blood cells. In polycythemia vera, this is an absolute increase in red cell mass. So red cell size increases. In this, you can see kind of symptoms that are dizzy, headache, vision issues, itching after a warm bath is a common one, and easy bruising or bleeding with little or no injury. I've seen these asked about in relationship to understanding the relationship to erythropoietin and where it's acting on and where it's released from. That's when I've seen polycythemia questions on this exam. Multiple myeloma or myeloma, this is characterized by neoplastic proliferation, so increased growth of a single clone of a plasma cell engaged in production of a monoclonal single immunoglobulin. Okay, so that's the interpretation there. Usually it's IgG or IgA. Okay, so we have a B cell, a plasma cell that's creating a specific IgG or IgA immunoglobulin. And instead of doing that job, it starts and replicating normally, it starts replicating abnormally. So neoplastic, cancerous, and proliferation growth. So that's our multiple myeloma. Obviously, if a plasma cell is engaged in inappropriate growth and proliferation, that can lead to a whole host of symptoms down the road, given that it's part of our innate or adaptive immune system. You can see bone and back pain because these cells are developed and grown in bone marrow. So you could see potentially fractures there, so weakened bones, bleeding issues, an increased aggravation in arrhythmias. And really where you'll get asked about these things are when it comes to some of these pathognomonic pieces. So Bence-Jones proteinuria, that's commonly associated with multiple myeloma. So that would be a good pathognomonic, as well as a hollowed out or punched out bone lesion. So lesions that look like they have hollow spaces in them. Those are the two kind of pathognomonic lesions that I see asked about in regards to multiple myeloma, as well as what's the cell type. So the cell type is a plasma cell that's proliferating inappropriately. This is another B lymphocyte issue. I doubt they'll ask about this. If you got a question about Waldenstrom's macroglobulinemia, just know it's also B lymphocytes and it's specifically IgM, the antibody. So whereas this was IgG or IgA, this is IgM. Otherwise, I do not believe they'll ask you about Waldenstrom's macroglobulinemia. All right. They will ask you about the leukemias. There'll be definitely at least one question about like a case about leukemias. So we have our ALLs, our AMLs, our CMLs, and our CLLs, okay? So creating a little table or flow chart can be really helpful here. I'm gonna kind of go through some of the peak pieces, and I do think I have a summary table at the end. Oh, maybe I don't. We'll pull one up at the end. So ALL, acute lymphocytic anemia. This is, of all the leukemias that can occur in childhood, this is 80%. So it's a very common leukemia to occur in childhood. If one is going to occur in childhood, it's likely that it's ALL. It peaks between 3 to 5 years, so young children. You'll see your classic symptoms of cancer. There is an association with viral infection, radiation, and Down syndrome. Not saying a causation, saying an association. And typically, though, with ALL, in children, there's a 3 to 6 month survival without treatment. So if there's no treatment, it is very likely that it could lead to mortality, to death. But with treatment, there's 90% that get complete remission. So how do you interpret that? Well, it's very survivable if caught and treated. It's very deadly if not caught and treated because it's acute, it's fast. So this is a cancer that could kill quickly if not identified and not treated quickly, okay? So key things for ALL, it's acute, so it's going to be fast development, fast growth. It's associated with children, childhood leukemia. It's the most common childhood leukemia. 80% of leukemias are ALL, but with treatment, it is highly curable, okay? On the other end of the spectrum are other acute leukemia is acute myeloblastic leukemia, or AML. This could also be called acute non-lymphocytic leukemia. There are 8 subtypes. If we're going to categorize this as a part of a family or a population, we'd say this is the most common leukemia in young adults, adults aged 15 to 39. So we could say also like post-puberty adults. You can see splenomegaly, bleeding disorders, etc. A kicker pathognomonic is the R rods in your cytoplasm. So if you have a question about R rods, think AML, or if they ask you what you could see on histology, R rods would be your pathognomonic lesion for this condition. It's a poorly differentiated neoplasm. You could live up to a year with chemo. The cure rate, though, is much lower. So this one, even with treatment, the cure rate is low. So this is more deadly leukemia. If we're comparing the two acutes, ALL with treatment is much more curable than AML with treatment. If we're talking about with no treatment, if neither of them got treated, ALL would be more deadly than AML, because AML you could live a little bit longer without treatment. Do you see the difference between what I'm saying? Okay, because they'll often ask these type of like mortality questions or longevity questions in combination with the patient's receiving treatment for, or the patient refused treatment for, and then understanding which one would have a longer survivability rate. So that's why it's important to kind of be able to separate the two. Yes.
Lineage of cell lines that get affected by this.
Mm-hmm.
So is ALL affects all cells created in bone marrow?
Lymphocytic, all of your lymphoid cells. So on that lymphoid lineage that we talked about, that's why if you can remember that lymphoid lineage, all of your lymphocytic cells will be affected, correct? The myeloid cells. So if we remember the split between the two, and our myeloid lesion and our lymphoid lesion, all those myeloblastic cells, the non-lymphocytes, so the non-Ts, the non-Bs, that's who's going to be affected in AML. So that's why that's really one of the reasons I teach first kind of that hematopoiesis, because if you can separate those two lineages, the lymphoid lineage, which has our T cells and our B cells, our natural killer cells, and then the myeloid cells, which has like all your granulocytes, your red blood cells, et cetera, you can really help understand some of these terms without actually having to memorize. Yeah.
This is also called acute myelologists.
Yes. Absolutely. Yeah, you'll see, and acute non-lymphocytic leukemia, right? So it could be, you could have all three of those names used. They will often refer to it as acute myeloblastic leukemia, but I've seen myelogenous on NPLEX before. They will likely never refer to it as acute non-lymphocytic leukemia. So you'll see only an AML on an NPLEX in regards to this condition. Okay, so those are our two acute leukemias. ALL, kiddos, really common in kids, deadly if not treated, really curable if treated, okay? AML, young adults, also acute, can live a little bit longer than ALL with treatment, but not so curable. Even with treatment, only a 10 to 15% cure rate, okay? Which if you think about the cell types involved, myeloid cells, there's a lot of cells on the myeloid side. And so if you have a fast growing myeloid lesion cancer, and all those cells are kind of all that myeloid progenitor cell is cancerous and not allowing you to really create any of your innate immune system, there's a high chance that even if you could get an infection and not have an immune response, your blood cells could start going wonky, your platelets could have issues. So you could see like how all of that lineage could potentially go bad really quickly. Okay. All right. Now we're moving into CLL and CML. So we're going to move from AML to CML. So now we're at chronic myelogenous, or you could also say chronic myeloblastic. So you can see both of them use leukemia. Okay, CML. Median age of diagnosis is about 45 years old. So this would be a cancer that we'd see more in the adult population. Is very uncommon before 10 years. So this is at least common or less common in children. You're more likely to see it diagnosed in adults. Your median survival is 4 to 6 years. So you have a decent survival rate, longer survival than the first two. You'll see a well-differentiated granulocytic leukemia that could include any cell line. So even though it's on the myeloid side, you can see any cell line, including the lymphoid cells, become affected over time with this chronic leukemia. It will be slow the first 3 years, typically when it's only dealing with the myeloid side. If it does kind of start to include all cell lines, including the lymphoid lesions, that's the accelerated phase, and that's when the majority of people die off from CML, is when it moves from slow to this blast crisis or accelerated phase. Signs and symptoms are classic. One cytogenic abnormality that's common, so a genetic component that's common with this CML. In fact, you could say arguably all patients, right, 95%, all or almost all patients who have CML have the Philadelphia or PH chromosome. So that genetic predisposition. That's the most common thing I see I've tested for on CML. Is it's adult, not kid, so the population, and what genetic inheritance or genetic mutation or genetic chromosome would set you up for this condition, and it's the Philadelphia chromosome. Okay, and our last one is CLL. This most often affects adults over the age of 55. It does not mean it can't affect kids. It just most commonly affects adults, okay? Patients will pass from cytopenia, secondary to bone marrow replacement, or from an infection due to immune system suppression. Remember, this is your lymphocytic side, so your lymphoid cells, your B cells, your T cells, your natural killer cells. You'll see any mature appearing lymphocyte looks morphologically no different than its normal counterpart. So it can be challenging to identify what cells are cancerous because they could look identical to their other counterparts. And so in that instance, this is often an insidious onset where you're asymptomatic outside of maybe enlarged lymph nodes, some fatigue, and really unpronounced symptoms. Your you could live for a long period of time with CLL without passing, without mortality. Obviously, with treatment, you can prolong life, but this is one that probably has the slowest natural death rate. So this will be the slowest one to kill you off without treatment. And you could probably live the longest with this if caught. The issue is oftentimes because the symptoms are insidious or asymptomatic, it's often not identified. And so it's not identified until a patient presents with bone marrow replacement or infection that sets them up for death. But they likely have been dealing with this for a long period of time prior to that. Okay. So those are our leukemias. So if you were asked about what's the most common leukemia in children, ALL should pop into your brain, right? Does it mean that you couldn't see AML or CLL in children? No, you absolutely could, but ALL would be your biggest childhood one. You should jump to that. The least common in children is going to be CML, okay? The other two you could see in children, but they're more commonly diagnosed in adults. ALL is your most commonly seen leukemia in kids. Yes.
Like different lymph that are swollen above the lymph diaphragm.
Not necessarily as much. You're thinking more of your lymphomas. I think you can have lymph node involvement, absolutely. But I think I would lean more into your lymphomas. We'll get into that here in a moment. Yes, absolutely. Good lead in. Yeah. They're all lymph cancer stuff. So yeah. So this is what we're talking about with the lymph nodes, is the Hodgkin's and non-Hodgkin's lymphoma. So those are your leukemias. Now we're going to talk about our lymphomas. So Hodgkin's and non-Hodgkin's lymphoma. So we'll see here with non-Hodgkin's lymphoma, it's the most common lymphoma. It is also more deadly than Hodgkin's lymphoma. So non-Hodgkin's is more common and more deadly than Hodgkin's, okay? Prognosis of non-Hodgkin's lymphoma is going to be based on the grade, diagnosis, right? The severity. When we look at Hodgkin's lymphoma, then, when it comes to kind of incidence or onset, you'll see a diurnal, essentially, or bi-diagnostic age component. You'll see 20 years old, so young adults, or around 60 being diagnosed. So think young adults, teens with Hodgkin's, or your elderly geriatrics with Hodgkin's as a diagnosis. So you'll see them kind of arise in both those two populations. Does it mean that other people can't get diagnosed with Hodgkin's lymphoma? No, anyone can. But the prevalence, the incidence is higher in these kind of two groupings, young adults and really like think maybe postmenopausal beginning of geriatrics, okay? This can be very curable. You can see a familial component, so a genetic component, but the curability or the treatability of this depends on the stage of diagnosis. The classic symptom that you'll see is painless swelling in your lymph nodes in the neck, underarm, or groin. It typically starts with one single asymptomatic node, and then it will spread. You could see intermittent spiking fevers, and then your other classic kind of symptoms of cancer. At the beginning, you could see a lymphocytopenia, and your classic cell type, your pathognomonic cell type, will be Reed-Sternberg cells. So think Hodgkin's, Reed-Sternberg. Okay. Blood stuff is when we see the most like pathognomonic cell types. With non-Hodgkin's, like I said, it's more common and more deadly. It's associated with immunoblastic lymphomas as well as Burkitt's. So you'll see non-Hodgkin's and Burkitt's discussed together. When you're dealing with non-Hodgkin's lymphoma, you'll see it is more of a malignant cancerous growth of your B or your T cells. So those are the cell types that are growing out of whack, essentially, in your lymph node. And you'll see monoclonal proliferation of lymphocytes in the immune system, lymph nodes, bone marrow, spleen, liver, and GI tract. So it's not immune to just one site. Non-Hodgkin's lymphoma, you could potentially see a bilateral presentation versus just the unilateral single lymph node that starts. Okay. Now I mentioned Burkitt's, so it's also a lymphoma. So I want to keep going with the lymphoma train. Burkitt's, it starts with B. It's a B cell tumor, B lymphocyte tumor. And your swelling is specifically going to be seen maxillary or mandibular. So mandibular swelling or maxillary swelling is typically where you'll start to see lymphadenopathy. This is also another B. It's associated with Epstein-Barr infection or virus in the US. Can also be associated with malaria in Africa, or really anywhere that malaria is endemic. Okay. It could predispose you to non-Hodgkin's lymphoma, right? I mentioned that. Non-Hodgkin's lymphoma related to Burkitt's. So if you get Burkitt's, you could be predisposed to non-Hodgkin's lymphoma. Burkitt's is B cell tumor, typically in the mandible or maxilla, associated with EBV and malaria as your kind of microbe components. Okay. That's your cancers. If you know just that at this point, you will do fine on most cancer questions. If you want to go deeper, like, or most of the blood cancer questions, if you want to go deeper, fine. I don't think it's worth it at this point. I think keeping it simple and some really easy ways to differentiate, that will give you enough so that you're not confusing yourself on the test. That's the most common reason people get these questions wrong, is they start to cross them over because they learn too much about them. So if anything, I would just keep it as simple as possible for these like 7 conditions, the 4 leukemias, the 3 lymphomas. Okay. Okay. Awesome. Well, we did perfect timing. So we'll take a 10-minute break. I'll look at the chat to see what questions we have, and we'll start back up at 9, and we'll move into our discussion for neurology. This will kind of flow directly into our neuro PowerPoint.